So we've got a great lineup this afternoon. So we're going to kick off with Indra, who's going to be talking to us about kind of national data sets and chest imaging. Then next up, we've got Deeny from the Health Foundation, who's going to be covering social care data infrastructure. And last but not least, Ben Goldacre, who'll be talking to us about his new project called Open Safely. So first off, we've got Indra. She's the Director of AI at NHSX. And kick off. Go ahead, Indra.
Great, thanks, Maxine. And hello, everybody. This is like my first sort of virtual conference. So I find it completely bizarre looking at 4 people with not looking at anybody else, but I'm hoping there's at least a few people out there listening to us. I guess I didn't want to talk too much about the detail, but we were asked about this conference in particular to ask about the how and the why we did what we did, not really the what. So I just wanted to talk a little bit of an overview of some of the approaches we've had to data and data sharing in the NHS to look at our response to COVID and how we hope to embed some of that moving forward. And before I crack on, I have to say that quite a lot of what we did was due to the emergency regulations of the time we're in. But really, it was a lot down to the people that we were in. So quite often, some of you will know, we work in different organizations and we do things some people do things over here and some people do things over here. And this time during the pandemic and COVID overwhelmingly have brought people together. This common cause to try and use data in a way that will both help inform policymakers, but also people who are working on the front line to understand some basic things like where are beds available, or what's the oxygen capacity that a hospital has. Some real fundamental operational points. Bringing all of those different peoples together under this umbrella of the pandemic has been really inspirational. And people working towards a common cause to say, we need to do this, we need to bring data together in order to not only save lives, but also help those people who are actually saving lives on the front line. So that's the key message I want to bring across. And as some of you may have read on our NHSX website, but also on the NHS England website, we've partnered together with different NHS bodies to say, how do we bring data that is needed in the operational response into one hub or one sort of place? And we set up something called the NHS COVID-19 data store, which was primarily there to help with the operational response towards the crisis and help not only trusts and regions, but also the national policy team to really understand what was happening on the ground, and also to help those regions work together. And on the flip side, we've also done quite a lot of work with the research community, and I'm not going to talk too much about that because I know Ben is going to mention some of the work they've been doing with the DataLab. But the key thing is there's lots of questions people want to ask, and being able to have an area where people could come and say, well, I need this data to help me answer this question, or I've been asked to look into this particular clinical impact or operational impact, and actually being able to say, okay, I have a clear front door where I can go and understand what data is available to help me answer those questions, was another thing that we set up with lots of different bodies like NHS Digital, the Health Research Authority, HDR UK, which stands for Health Data Research UK. And what we set up was a front door where people could come to easily get a clear answer of whether they were able to have access to that data and then be able to get a response within a clear time frame. So some of these things are different ways of working, as well as different ways of bringing different bodies together. And whilst that may not seem terribly exciting, it is a different way of doing things that we don't normally do in the NHS. And what I have to say is this COVID pandemic has really brought that together. And what I hope to see moving forward is these different ways of working continue. The way that we've been collaborative, we work together, we've got a common goal to say, okay, this is our goal, we need to achieve it in a set time period. I do hope we see that moving forwards. And one of the great things we've also done that hasn't had too much publicity, but has been quite impressive. and I guess we've got to see what happens over time as we do it, is try and create something called an image data source for chest images. So as we all know, COVID is a respiratory response. Clinically, it affects primarily the respiratory system. And so one of the things we've done is partnered up with the Royal College of Radiologists, but also the BSTI, to say, how do we look at images, and is there a way that we can actually use some modeling techniques to understand maybe what the human eye can't see in chest images? So keep an eye out for that. There's a little bit of information on our NHSX website. It's called the NCCID, so do have a look out for that. I'm conscious of time, I'll pause there. Thank you. Over to you, Maxine.
Amazing. Thank you, Indra, for kind of laying the groundwork and the background for the national perspective of what we're doing with the kind of various data sets we have sloshing around that could be used for COVID. So we go from the kind of national lens and the single front door to a mansion that's got loads and loads of doors, which is probably the fragmentation of social care. So next up, we've got Sarah Deeny, who is the Assistant Director of Data Analytics at the Health Foundation. And the Health Foundation has been involved in doing some amazing work, specifically also looking at care homes, which for anyone who's been following the news lately has been a real kind of source of kind of tension for the real missingness that we see within the data involved in social care. So Sarah, without further ado, go ahead.
Thanks so much, Maxine. Yeah, that's right. So what I want to talk to you about today is, it's a little bit of a cheat because you've all come to a session on the NHS and it being a new dawn for the NHS. But what I'm going to talk about is actually the data that we don't have that exists outside the NHS, what we have been doing right now to try and help with that, and what we think we can do in the future. So as you'll all hopefully will have realised, that the COVID has hit people who are in receipt of social care, those who work in social care and those who live in care homes harder than many other parts of our society. Right now, there have been close to 13,000 COVID-19 deaths in care homes alone. Some parts of the country, up to 46% of COVID-19 deaths are in care homes. And we're seeing a massive range of impacts across the country. And as we saw this information come through and trickle through in January and February, I think no one could help but be really taken aback by the massive scale of the impact and the toll that was taking. We were seeing deaths, and I've talked about deaths here and I've mapped deaths here on this slide. But of course, what that doesn't tell us is the other impacts, the toll that is taking on people working in care homes, mental health, the toll that's taken on residents' mental health, their families, the other healthcare needs that might be going missed because of COVID-19. And what we really need, and what we wanted to start to do, is to try and have a look to see what can we understand about people who are living in care homes, so that we can not just figure out what went wrong, what went right over the last few months, but also inform as we go forward our response. And now, for those of you who don't work in this area, you might sort of think, yeah, hey ho, you must have data somewhere, sure. But one of the issues, and Indra alluded to it, is that often data in health and in healthcare and in social care is organised not around a patient, but around organisations. And so if we think about social care and how somebody moves through the system, you've got an older person who's living in their own home, and they start out and they might be managing well at home without any additional help, and most of their healthcare is going to be delivered by their GP. GP data sets, as Ben's going to tell you, are a real jewel in the crown of the NHS. Now, when that person's admitted to hospital, again, we can see an awful lot of their data and follow them through from the GP to the hospital because we've got an NHS number. And so we're going to know an awful lot of information about them. Now, if that person is then discharged into a care home for additional rehab or recovery, we're going to immediately stop knowing so much about them. Now, we might know something about them from GP records still, but we won't know what additional health needs might have arisen in that social care setting in the care home. We won't know what additional nursing care they might be receiving or community care. And sometimes we might stop being able to see their GP record if they've moved to a different GP. So essentially then the last point was, if you are living in your home, and lots of people, actually the majority of people receiving social care are living at home, and they're receiving a visit maybe from somebody every day who might help them to wash and dress. And here we don't know that. Some local authorities might have it, but having that information for the individuals and linked in with their healthcare data is something that exists patchily across the country. So different parts of the country have this all linked up, but we don't have one lovely national data set. So this then paints a picture that's a little bit despondent, right? Because it's very fragmented, and how on earth, what can we do now? And a lot of the time, particularly in sort of February and March, it started to feel like you were really trying to kind of tackle a mountain with a small spoon. But one of the things that we were able to do and are able to do right now is to actually start to use the healthcare data that we do have and some simple data science to look at who is resident in a care home. And so at the Health Foundation, we've got a partnership with NHS England called the Improvement Analytics Unit, and using address matching at on the healthcare end, so at this GP registration end, we're able to identify who lives in a care home. And so that's people who are paying for themselves and also people who are being paid for by the local authority. And so once you have that, you then start to be able to say, well, who's gone in and out of hospital? Who have that changed over time? What can we say about why they've gone into hospital? What are the comorbidities that they might have? And even though we're not actually using social care data, we can start to tell you a little bit about what needs these people have. And it was interesting, one of the things that Indra said was, oh, this might be a bit dull. And I've also said, oh, this might be a bit dull, conscious that we're all at a big fancy AI conference. But I think at these times, actually using data to describe a need, identify what we might be missing, identify patterns, is incredibly helpful and useful for decision makers. And so by just using the hospital data and knowing where somebody lives, these are two examples of two long-term conditions you might be particularly interested in if you're looking at risk of COVID. And so we're able to pull this by looking back 2 years from hospital admissions from care home residents, and we can see that actually across the country there's different spreads of different long-term conditions for different residents, and that might be able to tell us, start to pick apart what parts of the country might need different types of inputs, might need different types of protections. And even doing this kind of information really helps people to plan now for the next few months. And I know there are already emails zipping across today, and we've got some new data in, we're feeding that back into the people who are making some decisions over the next few weeks. And so even those simple steps have really helped us to make some decisions. But we don't think that's enough, and we think that what I would want to see, and what we want to see at the Health Foundation, is that we start to have the kind of investment and innovation that we've seen in the healthcare sector, that Indra's described, that Ben's going to describe, but we're going to see it in social care. And we think that there's a massive opportunity because there's digitization is being rolled out across the social care system right now. And if we've matched that with the kind of research and development and investment in talent that we saw in the healthcare sector, we could actually start to build a social care data ecosystem that isn't just about telling us what we need to know about the healthcare sector and isn't just about telling us about avoiding hospital admissions, but is actually improving the health and well-being of people who live in care homes, people who are receiving social care, and importantly, the social care workers themselves. And so if we're going to be really provocative, I think there's an opportunity to actually leapfrog in some ways where we are with healthcare data. So we can start to create a digitized and cohesive infrastructure from scratch, built around the person, not built around the organization. There's an opportunity to work with users of services and their families, and to actually develop an open approach and an open culture from the start of the work here. But we can only do that if we're going to invest in data workforce and in the social care staff, and of course in the social care sector itself. And I think getting the balance here is what's needed, is to work both locally with the social care system and with providers and with local authorities, but also across the network so we can start to get a national picture. And I think if we got that right and if we brought that together in the next few months, it hopefully won't take us 10 years, we could actually start to have a system that allows us to be able to improve the social care sector, the well-being of residents and staff, not just for COVID, but also for everything we might need to have in the future. That's it for me.
Perfect. Thank you, Sarah. And that was a kind of great I think, introduction and background also for many people who might not be aware of the huge gap that we currently have in our social care data infrastructure. It's very exciting to talk about hospital data, but I think the real gap in the figures that were emerging made us all hopefully have a bit of a wake-up call. So last but not least, in this kind of wee section of presentations before we start a bit of discussion, we have Ben Goldacre, who is the director of the DataLab at the University of Oxford, and who'll be talking to us about his recent project called Open Safely. Take it away, Ben.
Hey, hi. Thanks for having me. And it's creepy and weird that you're all in my spare bedroom. So I'm going to talk about Open Safely, which is a new secure analytics platform that we built very rapidly for electronic health records research using NHS data. And it's been created to deliver urgent results during the COVID-19 emergency. But I think there are a lot of generalizable lessons. But this is a very specific use case. It's not the answer to everything. It's just the answer for primary care analytics with useful ideas for other areas. So opensafely.org is now successfully delivering analyses across more than 24 million patients' full pseudonymized primary care NHS records, with more to follow shortly, linked to death from ONS, death in hospital from CPNS from NHS England, and test results SGSS from Public Health England via the NHS England data service, which Indra was describing. All our analytics software is fully open for security review, for scientific review, and for reuse. And it's this pragmatic and also quite an interestingly new and very secure approach that's allowed us to deliver our first analyses in only 5 weeks from project start. So I'm going to talk a little bit about what we've done, because our model is quite unusual and different. I'm going to talk a little bit about why it was successful. But before that, I think it's useful to cover why we need huge data sets to get insights during COVID. So the first thing is we need very, very large numbers to understand the causes and the treatments of what is a very, very new cause of death. We need very timely data. We need to get data as soon as it arises where possible, but you also need huge numbers because, for example, for our first paper, which is looking at features associated with death in a population of 17.4 million adults, in order to understand the increased or decreased risk of COVID death amongst people with diabetes or people with asthma or people with different cancers, you need to have as close to possible as all of the country covered, because you need to have enough deaths. Morbidly enough, you need to have enough deaths in each small group to be able to detect any statistically significant differences. So you need very large numbers, but you also need those numbers to be near live. Now, that almost brings you naturally on to the security model that we pursued. So traditionally, primary care electronic health record data research is done by taking enormous extracts of that data, and you'd remove name and date of birth and maybe the last couple of digits of postcode, and then you would do research on that. And these are typically small portions of the population, a few million people's records, and it's typically managed through trust. You do these large episodic extracts, and those get sent out to people to work on their machine at home. Now, there's a problem with that, which is that it is not as secure as I would like. And I don't think it's secure enough for a research platform that covers 40% or ideally the whole of the population. And that's because of the re-identification problem. So primary care data is extremely detailed, and so it's very vulnerable to re-identification attacks. And these are the legitimate concerns that privacy campaigners and security researchers worry about. To put it in very stark, practical, concrete terms, I could find my wife, and in fact, you could find my wife in any of the electronic health record research data sets with a single SQL query. This is a nerdy crowd, right? I can say SQL query and nobody's baffled. I can't see any of your faces. Well, actually, I'll pretend I can, just to freak you out. I can see into all of your homes. Okay, so I can find my wife with a single SQL query. I just go, okay, select NHS pseudonym where they had twins in 2013, a baby in 2014, and the event codes moved from London to Oxford in 2015. And then I found only one row, only one patient that looks like that, and that's my wife. So having re-identified my wife, I could then, in principle, this is a bad taste example, but it's okay because it's me and my wife. She's consented to this bad taste example. I could then see, for example, has she had chlamydia since we got married, which will be a surprise. I could find all kinds of embarrassing things about her past that she might not want me to know. So this is why we need to manage primary care records and indeed all medical records as securely as possible. And that's why, to my mind, large downloads are not sufficiently secure. So we've done two things to put road bumps in the way of that kind of security threat. We didn't want to rely just on trust, which is the traditional model. Instead, we wanted to rely on proof. So we did two things. Firstly, we don't do huge data extracts where you take millions and millions of patients' records out and then let researchers download them onto their own desktop and do work on it. Even though you might genuinely have very good reasons to trust those people, you want proof rather than trust in trustworthy people. So instead, we built our analytics platform inside the EHR data center where those records already reside. So we collaborated, and Open Safely is all about collaboration. It's a collaboration between the DataLab at the University of Oxford, which is my group. It's a mixed team of software developers, traditional academic researchers and clinicians, all pooling skills and knowledge to turn health data sets into tools and services, as well as pure academic research papers. The EHR group at London School of Hygiene and Tropical Medicine, who are really the A team for electronic health record research. TPP, the electronic health records company, who run the software called System One that runs in about 40% of general practices in the UK, and NHS England, who are managing all of the information governance. And indeed, we are all working on behalf of NHS England. And I have to say that has been an enormous pleasure, and they are extremely smart, extremely gifted people with all of the right ambitions. So we built our data center, our data analytics platform inside the data center where the records already reside. Now that's really important because it means there are no large extracts. There's nobody downloading data onto their desktop, so you don't know what happens next. But also, crucially, it means there's no very expensive and slow process of extracting lots and lots of data because you're already at the place where the data already resides. Secondly, crucially, we've written software that has tiered layers that are increasingly non-disclosive. So we didn't just use a simple off-the-shelf trusted research environment. And I haven't got time to go into the details, but if anybody's interested, you can ask questions, or you can indeed go and look at our full software in GitHub. We built tables which, by definition, researchers never get. By design, researchers never get naked SQL access to the event level data that would allow them to do the re-identification attack that I described. So we go a long way beyond prior models. The last thing to recognize, though, is that this is fully portable. So I'm a big fan of long-standing NHS digital plans to take an extract of primary care data and put it in one single location, whether it's NHS Digital or elsewhere, where it is held securely and in a trusted research environment. And all of our code is written to be completely portable. So whether NHS Digital do that, or NHS England or NHSX, our code can just be repointed to run against those other data sources. And that's really important to write portable code, but also to write modular code. And to me, that's what's been missing in the health data research landscape. We've got 45,000 lines of code on GitHub from my group. We've also got thousands of GitHub issues. And when I look around the health data research landscape, I don't see so many other groups sharing. And I think that's one of the reasons why we've seen slow progress. So really big on open working methods. Every single line of code from this project is shared in the open, and we're sharing this as an open resource, not just for practical reuse by other geeks, but also for scientific review and also for security review. I think I should probably stop talking quite soon, but just before, it's funny, I can't even catch the eye of Maxine. I'm just rambling at my screen in my spare bedroom.
Yeah, you're okay, you've still got a minute.
Okay, so I think why it works is really important to cover. So first up, it's all about teamwork, and it's all about the team, and it's all about open and collaborative ways of working. And open and collaborative ways of working doesn't mean going to lots of meetings together. It means the real, genuine technical underpinnings of collaborative working. It means this entire project lives in GitHub. Every single member of the group from the EHR research group at London School of Hygiene and Tropical Medicine had to go through a trial by fire of learning how to use GitHub, Docker, Python, SQL, YAML to represent the study definitions. And it was glorious. It was fabulous from the very outset. They were people with a real computational data science mindset. They were the best possible group to collaborate with on this kind of work. But it all comes down to not teamwork in the sense of just being really nice, although we are all really nice and that's really important, but also the technical infrastructure of collaboration. Also, working alongside an EHR software company has been fantastic. I mean, people often get really grouchy about them. There is a spectrum of justification for grouchiness. I think secondary care vendors deserve a little more grouchiness than primary care. I have to say, EHR researchers, EHR academics and EHR developers working side by side is a match made in heaven. I don't know why it didn't happen all the time previously. It's been absolutely fantastic. And I think it's been really positive for the folk at the EHR vendors who we work with too. And that's because, again, of teamwork. So I think often EHR vendors find when they work with researchers, they're working with people who are used to working in kind of walled gardens for analytics. So R, or Stata, or God forbid, Excel or SAS point and click environments. And I think it's really frustrating for them because they're operating with general purpose programming languages, general purpose data management environments. And so often you get academics who think that they know everything about data management and analysis, then kind of rubbing up against EHR vendors who feel like they know a lot about EHR management, and why don't the researchers know as much as they do about Python and SQL and how all of this stuff works. And actually we were a good fit from the outset because we cut our teeth on building things like open prescribing and other practical services and having full stack commercial grade software developers in our team. But I think we have all leapt light years ahead, and although it's morbid to say it, we've had a really inspiring and exciting pandemic. It's been a great time, and everybody has picked up new skills and new friends and worked in one giant Slack conversation from 6 a.m. until 2 a.m. Not that everybody has to, only when they choose to. And none of us have met any of the others. At some point, we will go and have socially distanced Prosecco in an open space in a 3 meter by 3 meter matrix. And it will be, for the most part, the first time that any of the people involved have met any of the others. And I think that proves the point of how, you know, these people don't know each other from meetings. They know each other from pull requests on GitHub. And that is a beautiful, beautiful thing. I'm done.
Amazing. Thank you, Ben. And there's definitely a whole bunch of people who I have only met through their open source little avatars. And so if I were to ever bump into them into the street, it would be quite an experience. So we've got loads and loads of amazing questions coming in. So just to let you know what kind of the logistics and timing is going to happen. Before we break for our next session, we've got about 10 minutes of just a appetite whetting group discussion here. And we've got a quick kind of pause, toilet break, go hang out with your kids break for 15 minutes, and we're back at 3 for a 45-minute Q&A. So if you've asked a question now, and I can guarantee we won't have time to get through to them all, we have stored them to be able to ask them in the next session, so make sure you kind of tune back into our Q&A at 3 p.m. So before we ask, I can ask a few questions that are coming in, which I think there's a nice kind of theme. Just a really quick logistical one for you, Ben. How can someone get access via Open Safely?
You mean access to the underlying data?
Yeah.
Okay, so we've got a roadmap on that, which we're just working out right now, and we'll be putting that online at opensafely.org. The only thing I would say is we've been up and running for 8 weeks and we have £0 funding. There are data research platforms that have been running for years and years that have had tens of millions, which I think struggle to answer that question, but we are open by design. I should say though, just to be absolutely clear, what our approach and our software has done is push the envelope of what it is possible to permit access for. But this is not our data. We do not control it. And actually, we don't wish to. There are some really concerning aspects to the way that people talk and think around data and data ownership and data management and data controllership in the academic community, which I think are actually quite unhealthy. So there are lots of large cohort studies and data sets where it's extracts of NHS data and people take, for sometimes understandable practical reasons, a kind of proprietorial stance, and they say, well, I'm in charge of this and I decide who has access to this. I think we need to push forward from that. So we have made it possible, we have made it safe for data on this unprecedented scale for primary care data to be accessible and to be analysable. I don't think it would ever be appropriate for me to have the last word on who has access to that. However, we have to be part of the process of deciding who has access, simply because this isn't your grandpa's epidemiology research project. You can't do it in the simple walled garden of R or Stata or SAS. You need advanced computational data science skills. So we're discussing the details on how to manage access, but it has to have a combination of people like NHS England, and I think really extensive PPIE, but also part of the screening is, are you not just somewhat competent, but absolutely fluent in tools like GitHub, Docker, Python, SQL, YAML, basic computational data science skills, I would say, but that is somewhat outside what you would see in your average epidemiology research group, who have fantastic and outstanding skills, but just not necessarily those kind of open, collaborative, computational data science skills.
Yeah, no, absolutely. So going back to something you just said a little bit earlier, there's obviously a spectrum in this conversation of kind of centralizing data to keeping it where it is, to trying to make some sort of sense of fragmented data sets. So Indra, Sarah, what's your view on the centralized versus keep it where it is model when it comes to access to data? And I guess to add on to that, how has COVID, if you think it has, changed your perception of the kind of centralized versus local model on data storage and access?
I mean, it's a really good question, and the difficulty always goes down to the way our health and care system is built. We don't have a sort of a one, people quite often come to us, and I'm sure lots of us have all been in the position where they say, I've got a product or a technology and I want to put it into the NHS. It's not that simple as, okay, here's one person, it's their decision and off it goes. I would say what we've been doing during the COVID response, and Ben's alluded to it quite a bit, is bringing some of those operational bits of data that are really useful to bring in nationally has actually helped us. And Ben, I think you really put the nail on the spot at the end. Like analysis, I always get the name wrong, analysis and analysts. They're an amazing group of people, but I think they're kind of, the way we utilize them in the NHS has changed dramatically over time. And what we've tried to do over this period is really try and help them with some new skills like coding in Python or R, and looking at data in a slightly different way to help them with some of the predictive models. And I think the bringing data in to enable us to do some of that has been really helpful, but that has also meant that people on the ground and regions and trusts have also learned from those communities being built. So I think it's a catch-22, because it's not just about bringing the data into a centralized model, it's also about the change management that goes around that as well, and all the infrastructure. I can see lots of questions coming through on infrastructure and platforms, which is a complex task. So I don't want to go into too much detail, conscious of time. Sarah, I'll hand over to you.
Thanks. I'm going to cheat a little bit, and I think what COVID has shown us is the need to have a balance between the two, and to make sure that the right people have the data at the right time when they need it. And sometimes that's going to be nationally, because of an infectious disease, it doesn't stay neatly in one place, so we do need to be able to follow it across the whole country. But equally, we also need that local teams. I mean, this could be, London or Manchester. I mean, we're not talking about kind of a small village somewhere. Have access to data that's relevant to the job that they need to do and the advice that they need to give. And I think how COVID has changed is that I've probably become a little bit more militant about the need that we need to have more open access to data where it is safe to do so, and that there needs to be a good reason why that is not the case. And so I'm not talking actually here at all when I say this about individual level data. So I'm not talking about the kind of identifiable data Ben's talking about, but just at a very basic level, where outbreaks have occurred, or even, we know that having easily accessible information on where care homes are, which, you know, you can get from the web, but you kind of have to do some scraping and you have to go and get it. And I've also heard stories from local analysts about having to copy back down information that they've sent centrally to go and have a look at it again. And I think it's those sorts of things that when people are working at pace, it can be very easy to kind of forget about how people are actually using this data on the ground and the difference that a day or two might make in terms of decision making if they don't get it back quickly enough.
Yeah, I think that's an excellent point. One thing that I think we've all been witness to the past couple of months is a case of sort of a need for more haste and less speed. And I think that this has exposed the kind of cracks and opportunities that sit across NHS and social care data. Where do you think some of the cracks in some of the speedy elements of the work that's happened has emerged? So Ben, you know, you've mentioned that you delivered a project within 5 weeks on zero funding. You know, that presumably will long-term provide a sustainability challenge. You know, where do you think are some of the cracks emerging given the speed at which lots of this work was put up and running, which is amazing, but calls into some kind of longer-term questions?
What do you mean by cracks?
So there's lots of people will, so COVID Directive is a really good example. So data was shared. And there's been a kind of cultural opening up of lots of people willing to kind of collaborate in a way that hadn't been done before. Like, do you feel that actually that's going to be closed up very soon and we're going to go back to business as usual? Or do you feel that some of the infrastructure that we've been witness to across the system was good in the immediate urgent response, but actually might not stand the test of time because it doesn't have the appropriate skills, talents, or infrastructure or legal backing or commercial model underpinning it?
Oh, I think I see a huge amount of good coming from this period, both proof of concept, but also creative destruction. I think we will see that overall during COVID, everybody has become more like themselves. Every organisation, every individual, and for the most part, that's been brilliant. You know, I maintain my sunny disposition in the face of all the evidence. I think, when you look at something like Open Safely, we've been pushing this at funders and others for years, never been able to get any money to do proper open source analytic frameworks for primary care data. And now we've shown that it can deliver really quickly, it can open up huge collaborations, and it can open up collaborations beyond the edge of your own network. We were doing that in a small way with open prescribing for a while. And it's been really great to see other people adopting those methods over the course of the last 5 years. And of course, there are other people out there using, you know, GitHub and open approaches, but it's grown gradually. I think also in the past, people have said, oh, well, theoretically, it should be possible to make a trusted research environment for primary care data. Now we've done it, and there's no way back. I think the great stuff that you see in NHS England, there's no way back from that. I think equally, though, without wanting to sound too dark, COVID-19 is quite a well-prescribed set of problems, and it will be possible to see which approaches didn't deliver. And I think it will be really important to make sure that we preserve the approaches that did work, but also to have really frank discussions about where we spent lots of money for things that didn't work out. And I don't mean things which were good blind alleys that were legitimate at the time, but things that were foreseeably not going to deliver and then didn't deliver. I think, I hope that we will have a good period of reflection around that as well. And I don't think that should be tough. You know, that's part of how you evolve as a community and make sure that you're focused on meeting patient needs.
So I'm going to step in here as the ruthless timekeeper. Thank you so much, Ben. So we're going to have to wrap up, and I know the special ticket holders can go into the next Q&A session. So I will exit now and say thank you and let Maxine take over. Thank you so much.
Want access to more CogX videos? Subscribe now for free at cogx.co.